So the last positioning recording that we're going to do this semester is for paranasal sinuses. Um, and a lot of this we're going to run through pretty quickly because we've already covered most of the projections. We're going to fine tune and tweak a couple of them, but for the most part, the positions projections are going to be things that we've already talked about before. So we talked about this. Sinuses are just a hole or a cavity inside of the bones, and sinuses, be they mastoid processes or truly paranasal sinuses, function to lighten the bone. In the paranasal sinuses, they also work as resonation chambers. They kind of give you sound to your voice, specific sound and quality to your voice. So a resonating chamber, they decrease the weight of the skull. They aid in warming and moisturizing the air before they get down to your lungs, so that it doesn't. It's not quite as much of a shock to get to your lung. The cold. They act as a shock absorber in trauma situations, but possibly they can trap and isolate some things that you breathe in before they get to your immune system or aid in your immune system. So they start to develop early in life. The maxillary sinuses are really the only ones that are demonstrated at birth. So if you ever get a baby through the ER and some ER doc who has a tendency to like to shoot x-rays on everything orders a full series of x-rays, sinus x-rays on, say, a 1-year-old, and it does happen, you might want to gently remind them that the only sinuses the kid has at that point are maxillary sinuses, and would he like for you to shoot a limited series? And you may get shouted at for it, because some of your doctors have a tendency to think that nobody should question them because they've been to school for so long. And that's just the insecurity on their part. And it should not hamper you from seeking to take care of your patient and limit the radiation dose. That's part of our job. So by 6 or 7 years of age, the frontal sphenoid sinuses appear, and the ethmoids don't fully develop until about adulthood. So the maxillary sinuses are the largest and the most symmetric, and they're found inside the maxillary bone. They're pyramidical in shape, but the peak of the pyramid, the apex of the pyramid, is pointing downward. For some reason, we call them the antra of Highmore. I have no idea where that name came from. You can look it up if you want to and share with the rest of us. So the frontal sinuses are the second largest, and they are paired. Even if you can't see the septum in between them, there is a septum there, so that there is two. They're located between the vertical plates of the frontal bone, and they vary greatly in size and shape. Sometimes you'll get a patient for sinuses or a skull, and it looks like they've got a head of cauliflower sitting on the forehead. They're huge, sometimes. So sometimes they're absent, but even in the cases where they're absent, you can see the outline of them. It's kind of strange. The bone, the density of the bone appears to be the same, but the outline of the sinuses are still there. And then they're rarely symmetric, meaning they're not identical on both sides. So look like this. Frontal sinuses are here. Maxillary sinuses are here. Ethmoid sinus that's kind of these two streams here, and then you've got sphenoid sinus in the middle. So the sphenoid sinus is normally paired, but sometimes it will be a standalone sinus. So sometimes it's got a septum separating it into two, but most of the time there's going to be two of them. Okay, I just said that backwards. Most of the time you have two, so you've got a septum present, but once in a while you'll have a single sinus in the sphenoid. It's not paired. So it varies in size and shape. usually asymmetric whenever you have two, and it's situated right below the sella turcica. That's the thing that we look at whenever we evaluate whenever we're uh, trying to evaluate the patient for a basilar skull fracture fluid in the sphenoid sinus, and that's the sphenoid sinus right there. So sphenoids here, ethmoids, the ethmoids, the frontal sinuses, and then you've got the maxillary sinuses there. So the ethmoids more closely resemble the mastoids. So it's often referred to as the labyrinths, and there are a whole lot of different individual air cells. So there's generally 2 to 8 anterior, 2 to 8 posterior or middle, and 2 to 6 posterior. So you could have as many as 22 individual air cells. Very difficult to make any kind of diagnosis of a sinus infection, ethmoid sinuses, unless you take the patient to CT. But on diagnostic x-ray, you can easily see sinus infection in the maxillary sinuses. You can usually diagnose the frontal sinus. On lateral, you can see the sphenoid sinus pretty well, but the ethmoid air cells, there's just no way that you would be able to make an accurate diagnosis on diagnostic x-ray. So they're inside the lateral masses of the ethmoid bone. So again, altogether they look like that. So our essential projections, we're going to shoot a lateral, same lateral we looked at before. The Caldwell, we're going to do a little bit of variation on it, remembering that we're looking for air fluid now, so we want a horizontal central ray. So we're going to accomplish with patient positioning what we would have otherwise accomplished with a central ray angulation on a normal Caldwell. So you'll see that in a minute. We're going to have a Waters method. We're also going to have an open mouth Waters projection, and we're also going to have a positioning-wise same SMV that we looked at before. So technical considerations, we want to shoot them upright because we're looking for air fluid levels. If you have a patient who can't get upright, then we're just going to have to do cross-table lateral best we can, and sometimes that is going to involve only a cross-table lateral. If the doctor orders a sinus series and he insists on frontal views, and the only thing that you can get that would demonstrate the air fluid levels would be the lateral, then so be it. It'd be a lateral. You might be able to diagnose a sinus that was full. Let's say this guy had a sinus infection in his right maxillary sinus. You would probably be able to deduce that the patient had, if his history was, I've got pain here, I've got recurring sinus infections here, and you shot this patient laying down in an AP projection, and this sinus was occluded, meaning that it was full of goo of some sort, then you would probably clinically be able to deduce, yeah, this patient's got a sinus infection. He gets a sinus infection over here all the time, and he's got another one. Now, looking at this particular image here, and I'm going to kind of blow this up a little bit, you see how close the tooth root is drawn to this sinus. Okay, granted this is a drawing, but it's pretty accurate. Sometimes the tooth root will grow into the sinus, maybe not all the way in through the soft tissue, but tooth issues can cause sinus pain. It can cause sinus infection. Sinus infections can also cause tooth pain. So don't discount that somebody's got a toothache and they've got a sinus infection all at the same time. It happens. Let's see if I can get this back down. All right. So, looking for fluid levels, so upright if at all possible. If not, you just may have to take what you can get. So central ray, if at all possible, should remain horizontal. Shielding of patients, same thing that we've talked about before. Shield if at all possible. Collimate when you can. Don't collimate the anatomy off. Rules for collimation still remain. You don't want a collimated field larger than the anatomy that you want to see, and never ever larger than the image receptor. You want to utilize small focal spot to increase sharpness of recorded detail, and you want to make sure that you take patients' earrings out, their teeth out, if they've got removable teeth, necklaces off, and all that. So lateral projection, what we're going to see is we're going to see all four sets of sinuses. We're going to see the anterior and posterior dimensions, so we're going to see front to back, we're going to see top to bottom. We're going to see thickness of the frontal bone, and we're going to see the detail. We're going to see both of them superimposed on top of each other, but we're going to see the detail of the side closest to the image receptor. So if you happen to have a patient who's complaining specifically of pain under their right cheek, you might shoot a right lateral instead of a left lateral. Put the side of interest closest to the image receptor. So positioning wise, everything is the same. Mid-sagittal plane, interpupillary line, infraorbital meatal line perpendicular to the front of the image receptor or parallel with the long axis of the image receptor, interpupillary line perpendicular to the image receptor, and mid-sagittal plane parallel. Mid-coronal plane will be perpendicular. So the only difference again is central ray location and collimation. Central ray is going to enter 1/2 to 1 inch posterior to the outer canthus. We don't need to see the entire skull. The most posterior sinus that we're going to see is the sphenoid sinus. So centering no further back than just anterior to the temple is going to give us the sphenoid sinus. So open up your collimation and make sure you include the frontal sinus all the way back to the sphenoid sinus.